Thank you, Becky. So yes, I will do a brief introduction. So Dr. Elizabeth Holeman is joining us today. She is our palliative care psychologist here at the VA. And I can't do justice to what she does for our veterans in words. She helps with the inpatient team and also is the carer for Tootsie, our facility palliative care dog, and then also helps to manage outpatient veterans who are referred to her for palliative care psychology. She has a robust knowledge. Her presentation today will be amazing. And thank you, Elizabeth, for joining us yet again.
Oh, thank you so much. That means a great deal to me, especially coming from such an amazing colleague and human. So thank you. And thank you all for having me today. It's so nice to meet you all. There's so many people. I won't ask folks to introduce themselves individually, but it's really lovely to be with you, and I so appreciate the invitation. And so I want to be respectful of everybody's time. So I think I'm going to go ahead and jump in. I have some slides, and I always feel like, golly, Pete, we're 3 years into this, and I still feel inept when I am sharing screen and doing slides. Okay. Can you guys see that now? Hey. All right. I don't know how to make this thing go away. Okay. All right.
Yeah, we can see it good.
All right. I think I will turn off the subtitles, but if someone would find them useful, I'm happy to turn them back on. And I can't see the chat, so if folks have questions, feel free to.
I'll man the chat for you, Elizabeth.
Thank you so much. Awesome. Okay, so again, this is about veteran psychosocial issues at end of life. I'm the psychologist on the palliative care team. I've been doing this for shockingly like 13 years now, which is just really an awesome opportunity. And so we are going to do a little bit of a gallop today through some mental health and social issues that affect veterans at end of life. We're going to talk about sort of general information about military culture. Then we'll spend some time on PTSD, and we'll talk particularly about how that appears in our Vietnam veterans. And my guess is most of you are familiar with PTSD. Then we're going to spend a little bit of time on moral injury, which people, don't know quite as well. And then spend some time talking about military sexual trauma. So thanks for hanging with me. This is not the most cheerful discussion for a Cinco de Mayo, but hopefully will be interesting and useful. So in terms of just unique considerations for working with veterans, I think all of you know this, and particularly, I guess I want to stop and say huge thanks to all of you as our hospice partners. Thank you for the care that you provide for veterans. Thank you for the care you provide for all of your patients. It is such a tremendous gift and a tremendous service. And we don't provide hospice services, as you know, as part of VA. And so it's really marvelous for us to be able to say to our veterans and families, we are going to refer you to an outside hospice agency, and you are going to get excellent care. So thank you so much for that. And particularly for those of you participating in the Hospice Veteran Partnership, you've gone above and beyond to learn about veterans. And so that a lot of times veterans can go unrecognized. And so just thanking people for their service, especially for our Vietnam veterans. I mean, even now I have veterans of the Vietnam War who, when we thank them, they'll say, this is the first time I've ever been thanked. I've had a number of Vietnam veterans say that what happened when they came home was at least as traumatic as anything that happened to them in Vietnam. And so really recognizing people's service is tremendous. And we'll talk about this fact that military culture and training influences a soldier's life and their death. And whether that death is when they're young or very old, it's pervasive. And what we find sometimes is that the influence of military experiences can begin to surface as veterans age. So, it might be that people serve, they might be in combat, they may not, but their time in the military comes to an end, especially if they're not like a career person, and they come back home, they leave the military, they might start a family, have a job, kind of live their life. And their veteran experience maybe doesn't seem so salient, but then especially as they age, especially sometimes as they retire, and particularly if they become ill, those early experiences in the military become more and more pertinent. And we know that not all of those memories are benign, right? That we think about the value of life review, and it can be very healing, but it also can be very troublesome. And we'll talk about the different ways those things are integrated. But it's also really true that military experiences and relationships can be a tremendous source of strength and comfort. For some of our veterans, they are in their 80s, but the most important relationships in their lives were in their late teens and early 20s when they served in the military. So just a really rich experience that veterans bring. So let's talk a little bit about this notion of battle mind. This is an idea that VA developed to describe the kinds of things that military members are taught. So soldier training, it's designed to arm individuals with survival skills and the skills necessary to carry out their missions in adverse conditions. So and that training stays with veterans throughout their lifetime and can influence their end of life experience. So veterans are taught things like valuing facing fear and adversity with courage. These are people who look at something difficult and are taught, like, I can get through this. And it's really important not to express or sometimes even experience some difficult emotions, because controlling your emotions and tolerating discomfort, it's critical for mission success, right? So if you think about, if you are in the field and you experience a significant injury, or someone next to you is badly injured or killed, you can't in that moment say, like, oh my gosh, this is huge, I need to process this, right? It can put yourself at danger, it can put the person next to you at risk, and it can jeopardize the mission. So soldiers, military members are taught that mission success is the most important thing. Your survival depends on staying alert and disciplined and obeying orders. I'm always struck working in a VA setting by how many of our veterans, they can be plenty ornery. And yet also many veterans, it's remarkable to me how they sort of like take orders from us. We tell them to do things and they're like, okay, I will do what you say. And sometimes it's hard for them to articulate when they don't agree. Part of battle mind is having a really rapid reaction to change. You have to stay alert. You have to stay aware of what's going on. And it's your job to survive and to keep your fellow soldiers alive. I think that's something that's so noticeable, particularly working in a veteran setting. I'm always moved by veterans who have really significant needs. We'll be discharging from them from the hospital and saying, we want to get you some help at home. And they'll say, oh, I think there's probably another veteran who needs it more than I do. And you're like, no, it's really okay for you to get this. But there's this ethic of care for the people around you. There's also combat skills, right? Like definitionally, every veteran was taught how to kill people and multiple ways to do that, and how to sort of harden yourself to the presence of death and to being even an agent of death. And that's not something that a lot of other particularly young people experience. And that's something that stays with people throughout their life. And also this notion of limiting discussion to the members of your unit. There's a big priority set on kind of unit cohesion. And sometimes that carries on in civilian life to limiting discussion to members of the family. And of course, there's also cultural influences. There's a number of cultures where that is an important priority. So all of those things are things that our veterans bring with them into the experience of serious illness and end of life. So I just would ask you to kind of keep those things in mind and think about how those might show up when you're caring for someone in hospice. So we're going to spend a little bit of time talking specifically about PTSD, which my guess is you're familiar with. But I mean, I think one important thing to emphasize is post-traumatic stress is a normal response to an abnormal situation. It's what humans do when they are exposed to sort of inhumane experiences. It's not limited to combat exposure. Any trauma or terror, such as natural disasters or victims of crime or abuse, can experience PTSD. Interestingly, motor vehicle accidents are the #1 cause of PTSD in the non-veteran population. And then there's a long history that we haven't always understood, but we've known it's there, right? So PTSD was sometimes called shell shock or battle fatigue during World War II. In the Civil War, it was referred to as soldier's heart, which I just find really moving and quite eloquent. So it happens when someone has an experience, an exposure to a traumatic event in which their life or someone else's life is in danger. And the reverberations of that are that this traumatic event are persistently re-experienced. So that could be recollections, that could be flashbacks, that could be things like nightmares, could be sensory distress cues. I took care of a veteran of Iraq and Afghanistan who had experienced several like roadside bomb detonations. And when those things exploded, he was in Humvee and the gasoline was burning. And so for him to fill up his car was incredibly distressing. And he would drive his car into the last ounce of gas in the tank so as to not have to be exposed to that trigger. This kind of re-experiencing sometimes leads, or as part of the diagnostic criteria, leads people to persistently avoid associated traumatic stimuli. So that can be thoughts or feelings or conversations about the trauma. You may hear a veteran's family say, yeah, they don't really talk about their time in the military very much. They don't maybe want to watch movies about war, situations that can trigger sensory distress cues. As we come into the summer, I think we're all aware of the impact of things like fireworks on some of our veterans. Can really be distressing because it reminds people of firearms or explosions. And then there's other persistent symptoms that occur with PTSD, things like inability to recall some aspects of the trauma. And I won't get into the sort of neurobiology of this, but basically traumatic memories, most memories you have, like your memory of this discussion today, should you remember any of it, it gets like processed, right? And that's nice wrinkly bits on the outside of your brain, and then it gets neatly filed away. Trauma memories don't do that. They just get like shoved in the back of the drawer. They don't get processed, they don't get attended to, and they become this sort of like this thing that can sometimes really be hard to access. And when it is accessed, then it can come back in these kind of flashback ways. Also, we see people with PTSD who have a lack of interest in significant activities. They can feel really detached or estranged from people. They might have a restricted range of affect, just kind of shut down. A sense of a foreshortened future, that's a really big one that I think becomes particularly salient at end of life. We took care of a guy who was a Vietnam veteran who came into the hospital for what he thought was kind of a minor breathing issue. And it turned out he had really significant COPD and had this bad exacerbation and kind of suddenly was in the last months of his life. And we were distressed sharing this news with him. And he said, you know what? I've known this day was coming since I was 19 years old. So one of the features of trauma, and particularly post-traumatic stress disorder, is this sense of the fragility of your life and a notion that your life may be quite short. Unsurprisingly, other symptoms can include things like difficulty sleeping, irritability, outbursts of anger, hypervigilance. One of the things that I ask folks if I'm assessing for PTSD, I definitely ask, like, do your memories come back to you in ways that are troubling? But I also I'll ask the spouse, can they sit with their back to the door when you go out for a meal? Because a lot of our veterans can't. And that may just be part of that battle mind training, but it may be more of an indication of something like PTSD. So kind of a range of symptoms that you might see. The course of PTSD can be variable. So the onset can be acute, can happen really shortly after a trauma. There can be a chronic course, or it could be something that appears later in life. It could be a delayed onset. And how it manifests and who it will affect is unpredictable. We don't know all the reasons why one particular person will develop PTSD in response to a trauma while others don't. But we do know that soldiers with high combat exposure are 4 times more likely to have PTSD. We know that immediate treatment and ongoing support does help, and there are good evidence-based treatments, although by the time people are at end of life, evidence-based treatments like exposure therapies are not always necessarily the best choice because of the time course and because of they may have a waning ability to participate. I think it's also important to note that post-traumatic growth is a feature that we see. Tedeschi and Calhoun wrote about this in their kind of important study on post-traumatic growth, that sometimes when people experience a trauma, after they move through the trauma and process it, they find themselves with a new appreciation of life. They have deepened relationships with others. They discover in themselves personal strengths. They may experience spiritual changes. So while PTSD is extremely painful and distressing, I also want to be clear that that there can be growth that comes from trauma. But it's also true, and again, really important for us as we care for people with illness, that when trauma involved a painful physical injury, that pain can be a trigger later. And we'll talk a little bit about this in a few minutes about guidelines for interactions, but just remembering even kind of non-specific, just the experience of having pain. Like we had a guy who was in an underwater explosion in Vietnam, and like basically he got blown up and one of his lungs got blown up. And later in life, he had to have a chest tube. And so that was super distressing to him because it took him right back to that place. So just sort of knowing that when there's been trauma, that some of the things later in life can feel like echoes of that. So how prevalent is PTSD? I think it's important to note. So the estimated lifetime prevalence of PTSD among adult Americans is 6%, 4% among men and 8% among women. And it's beyond our scope today to talk about what accounts for that difference, but I think it is important to note that women do experience PTSD at a slightly higher rate. But what that tells us, and I think it's important to remember, is that not everyone who experiences a trauma develops PTSD. And interestingly, there's variation among the eras of service. So our Korean War veterans, about 15% of them decades later still had PTSD, and an additional 17% had PTSD and depression. The estimated lifetime prevalence of PTSD among our Vietnam veterans is 30% for men and 27% for women. So over the course of their lifetime, Vietnam veterans, and I think it's important to remember there were many women who served in every conflict, but particularly in Vietnam, that some of them are, that a pretty good sized chunk of them have experienced PTSD. There's this great study by Marmar and his colleagues about the course of PTSD over time for Vietnam veterans. And they found that it decreased over time, but still as late as 2014, over 10% of Vietnam veterans had clinically significant PTSD. 4 decades or longer after their war zone service, a number of these Vietnam veterans who were in combat with PTSD also had high levels of comorbid depression. So, these things don't travel on their own. And I think something really important from that study, they said an important minority of Vietnam veterans are symptomatic after 4 decades, with more than twice as many deteriorating as improving. So this is something that people live with for a very long time. And in some cases, it's not getting better, it's getting worse. Our Gulf War, Gulf and Desert Storm veterans, about 12% of them have PTSD in a given year. And our most recent conflict, Iraq and Afghanistan, it's kind of a wide range, but between 11 and 20% of veterans who served in Iraq and Afghanistan have PTSD each year. So in other words, PTSD is something you're likely to see in a number of our veterans. So, and there's different ways that people experience and kind of address their trauma experience. Deborah Grassman, was a nurse practitioner at the VA hospital in Bay Pines, Florida, and really has done a lot of really important work around veterans and end of life. She categorized 3 different types of responses that veterans have to war trauma. So the first is what can be called an integrated response, where you might hear people say things like, I've faced death before, I'm not afraid, or this sense of appreciation, like I faced death years ago and every day since then has been a gift. So this doesn't mean that their experience wasn't traumatic or that the memories don't still surface, but the veteran's open to reckoning with these memories and other symptoms, and they likely have experienced post-traumatic growth. So we can listen to these folks, invite them to tell their stories, celebrate their accomplishments, affirm the wisdom that they've gained, and we benefit from that as well. A second category is what she called incomplete integration of trauma. And these are the people that you see who you think like, oh yeah, that person is still experiencing PTSD. They say things like, most of my brothers stayed over there, or I didn't know who it was that came back. So these are people who have PTSD, history of substance use, really challenging relationships. A lot of anxiety or agitation or acting out might be coming from the trauma. You see people doing things like sleeping on guard. We had one guy who had been in the jungles in Vietnam, and he was at the Denver hospice in their old hospice unit over off of Monaco, I think. And he wanted his boots in the room with him. And it was the middle of the summer. He didn't need his boots, but he really was distressed if he didn't have his boots. And it turned out that he would sleep with his boots next to his bed in Vietnam. And if there were rats in the room, he would throw the boots at the rats. But all those years later, he needed to have his boots near him to feel safe and comfortable sleeping. So those are the folks that we see, and it's really clear that they're struggling. And then there's this third category that Grassman identifies that I think is really important for us to be aware of, which is this kind of apparent integration. So it looks like people are okay. They're generally pretty functional. But like, these are the people who are like, I don't want to talk about it. My life has been great, except for the years that I was in the service. And they look like they're doing okay, but then you look a little closer and you see some acting out behaviors. There may be the people who were always at the office and never came home. This white knuckle syndrome, like I am getting through life, but I am doing it by the skin of my teeth. So these are veterans who may just be having kind of undiagnosed or even a delayed onset of PTSD, and they've used a variety of behaviors to keep this trauma hidden. So veterans that have this kind of apparent integration trauma, we should be treating them with the same ways and approaches that we use with our folks whose trauma is more evident. So how do we do that? There are some really great guidelines, and my guess is many of these, but I think it's worth reminding. Like one thing is just to ask veterans if there are triggers of unwanted recollections or things that they find disturbing. Any experience of being restrained can be very difficult for veterans, especially if someone was a POW. So if you know someone was a POW, it may be worth asking specifically about that. Even if like the sheets are tucked in too tight, that might be really triggering for somebody. Or like the experience of a fever for a veteran who was in a ship when it was bombed and it was burning, like that experience of being too hot can be triggering. So just being aware that the physical experiences that we have in illness can trigger those traumatic memories. Sure, you guys know this, but just to remember, like avoiding sudden unannounced loud noises when veterans are sleeping, arouse them by shaking or by voice. If you're going to shake them, like sometimes shake their feet. You don't want to shake them. You don't want to yell. This is an interesting aside, but so my dog comes from an organization called Canine Companions that also trains service dogs for PTSD. And one of the things the dogs are trained to do is nightmare interruption. And in the civilian population where that skill was trained, they would train the dog when they became aware the person had a nightmare. The dog was trained to get up on the bed and like apply pressure or snuggle up to the person. What they figured out with veterans is when they're having a nightmare, the dog turns on the light and goes and pulls the sheets off the bed and sits at a distance from the bed because until the veteran is awake, right? Because remember, our veterans are trained in combat skills, and when you're traumatized, you feel like you're at risk. And so like I had this completely lovely veteran who like was always afraid he was going to hurt somebody in the hospital because he said, I will wake up swinging, right? So don't put them or yourself in a bad situation. Just give them plenty of space to wake up. When you're making physical contact with a veteran, verbally cue them in advance. Like, here's where I'm going to touch you, and here's why. Here's what I'm going to do. Offering reassurance and just remaining present. If the veteran, you kind of start to think like, oh, I think they're not really here. I think they might be somewhere else. Or if they're not making sense of their reality. I mean, if you don't feel safe or if they're too agitated by your presence, it's fine to leave. But you also can be a steadying presence and help reorient them. And provide for emotional and physical safety, even including asking about weapons in the home. I think that's just, it's always important that we provide a really safe experience. And helping reorient. So I took care of this veteran, again, a Vietnam guy. He was a sniper in the Marines. He was in Vietnam during the Tet Offensive. And he told me once, he said, I feel like I'm back there most of the time. And I said, well, how much of the time are you here? And he goes, about 50%. So much of his sort of experience in life felt like he was back there. So just helping anchor people, you are here, you are safe, this is where you are, helping them be oriented, and then giving choice. Help them keep as much autonomy and self-direction as possible. Even if they're immobile, you can ask, do you want your arms or your legs washed first? You know, I have a colleague who says, trauma-informed care is all about voices and choices. So hearing people's voice, hearing what their experience is, and giving them choice can be incredibly helpful. I'm throwing a ton at you. Do you have questions? Any? Okay.
I loved what you shared about the dog. That was really interesting. The
Isn't that
difference they would
amazing?
train the dog to help interrupt nightmares. So yeah, thank you for the stories that you're weaving throughout the information. I appreciate it.
Oh, thank you. I don't want to like be boring with war stories, but I just like, I think, well, for one thing, I think those examples, I think, can be really meaningful. And these veterans that I've taken care of, they're all gone, but they're all still here, right? Like, so thank you for letting me share them with you. So one thing Becky and I talked about is she wanted me to kind of specifically address if like questions around suicide. And as we were talking about it, I reframed that as the wish for hastened death, which I don't know is something that you all are, if that's a phrasing that you're familiar with. But essentially, I find that a very helpful way to think about that. Particularly, I mean, so when you're working with people on hospice, definitionally, the end of their life is expected and it's near. And there are times that people wish to hasten their death for whatever reason. And so I just think that it carries a little different freight than the way we talk about suicide generally. And I think we have to approach it differently. You know, a 23-year-old with bad depression saying, I want to end my life, we may have a really different response to them than someone with a terminal cancer who says, I want the end of my life to come sooner or to come on my own timetable. So there's this fantastic article by Hudson and his colleagues from 2006 about responding to what they call desire to die statements. And Becky, I think I sent you the slides. So this is all in the references at the end of the slides. But they talk about asking about the source of the distress and asking what would the person hope to avoid by hastening their death. So if people, I just had a guy this week say, I'm in terrible pain and I don't believe in euthanasia, but I was like, huh, tell me more about that. What's driving that? What are the feelings or the fears that you would want to avoid? And often it's some form of suffering, right? But suffering can be physical, can be spiritual, can be psychosocial or existential. And that Hudson article has some great 2 pages of really good questions and things to consider under each of those headings. But essentially trying to find out, because if somebody says, I'm terrified of being, I saw my mother die from cancer and she was screaming in pain at the end of her life, and I don't want that. That's a really different response than someone who says, I don't want to bankrupt my children with my care, right? So we're going to have very different responses to those. When we are thinking about risk factors for suicide, Thomas Joyner is this brilliant psychologist who has what I find to be a really helpful framework for thinking about risk factors for suicide. And he talks about perceived sense of being a burden, a lack of belonging, and habituation to painful stimuli. That really all of those 3 things need to be present in order for someone to take their life. And I think the sense of burdensomeness is one that we do see, particularly at end of life. People fear being a burden to their loved ones. Lack of belonging, I think, is something for us to be alert to, because I think the experience of serious illness can be quite isolating. And so if we feel like people are articulating a lot of sense of, my family's not around or my friends don't come around anymore, that can set off some alarm bells. And veterans are, I think, one of the reasons why veterans are at increased risk for suicide is they have been taught to be habituated to painful stimuli, right? And sometimes for all of our patients with serious illness, their illness experience habituates them to painful stimuli. So I think it's worth keeping those things in mind if we're trying to assess, is someone at risk? And so I always feel free, if you feel comfortable, to ask, do you have thoughts of suicide? The data is really clear that asking about suicide does not plant the idea in people's head. It doesn't prompt them to act if they hadn't been thinking about it before. And asking can be really important. Do you have thoughts of hurting yourself? Do you have a plan? Sometimes people will say, yeah, I've kind of wished I would just go to sleep and not wake up, but no, they don't have a particular plan. If people have a plan, then the next question is, do you have access to the means? I had one patient who absolutely talked about suicide, but their plan was to drive off a mountainside, but they were non-ambulatory. They were like bedbound. And so, you kind of have to take in the whole picture. And how we respond to that is, obviously always with compassion. You can, if you really feel like someone is at risk for harming themselves, if they're articulating, yes, I have serious thoughts about killing myself, I have a plan, they have access to means, you can consider safety planning. Like a contract for safety, the data for that is not good, like people promising they won't hurt themselves. But you can walk through, like, what are the things that trigger you to feel this way? What are the sources of support that you have? How can you reach out for help? And refer to the social worker on your team, refer to your medical colleagues. But I think just really for a lot of people, exploring what is it that you are hoping to avoid, and then how can we problem solve around that, can be really important.
I have a quick question, Elizabeth.
Yeah,
I was curious.
yeah.
Can you just unpack the phrase habituation to painful stimuli?
Oh, yeah. Sorry.
Thank you so much.
Sure. So the reality is that most methods of killing yourself are painful, right? In fact, you guys might have experienced this too. I just had a veteran this week. I asked him, do you have thoughts of hurting yourself? And he said, no, I'm chicken, right? Because actually, so Thomas Joyner's father died by suicide after multiple attempts. And when he finally died by suicide, he shot himself 3 times, right? Like, you have to withstand a certain level of physical pain in order to end your life, with almost all methods. So people who for whatever reason have become accustomed to withstanding physical pain, whether it's because they're veterans, they're trained to be tolerate pain. It might be because they're like athletes. There's any number of reasons why people, they are less frightened of pain than kind of standard folks. And really for us as humans, fear of pain is often really adaptive. So yeah, and veterans are taught push through the pain or disregard the pain or don't feel your pain. So that can be a risk factor. Does that make sense?
Yes, that's really helpful. And I had one more question too, sorry.
Yeah.
And I know this could be a whole nother presentation. So, but what I was curious is, with medical aid in dying available to people, in some community hospices do support that and some don't, it depends. But my understanding is the VA, do you refer people, or what if somebody does want to make that choice, what happens?
Excellent question. And I should have addressed that. I should have at least mentioned that on this slide. I get sort of insulated in VA land. So we're in Colorado, right? We have this medical aid in dying statute. But Katrina and Jill and I, right this minute, we are in federal land. So the VA is a federal agency. So we are not covered by state rules. We are covered by federal regulations and laws. And so in VA, medical aid in dying is not permitted. And in fact, we are not permitted to play any role in medical aid in dying. So we cannot, our providers can't be the ones that assess whether someone has a terminal illness or whether or not they have depression. They can't be the ones that concur. Ethically, it's a little dodgy even to refer patients, although I will tell you that, when that comes up, we absolutely have that conversation with our veterans, because of course our veterans don't, they think, oh, we're in Colorado, you can do this for us. And so we explain, the strictures around that, but we also, again, explore with them, what are you hoping to avoid? And if veterans are wanting to take advantage of medical aid in dying, we encourage them to, if you're going to go to hospice, we encourage them to ask on their own if hospice agencies will participate in medical aid in dying. But we can't, and we also can't say like, hey, Dr. Martinez at the university can help you. We can't do that kind of referral either. Jill, do you have stuff you would add to that?
I think you said it well. I do. I think I use the word educate as opposed to refer. Is I can educate them on what we can and can't do, but not necessarily give referrals. But I do educate on information in terms of other places that they can explore.
Yeah, like compassion and choices. I mean, we have told people, like, you can look at compassion and choices and get information.
Mm-hmm. But yes, the referral, or any involvement. And I know this is a conversation for a different day for a lot of hospices, but I feel like a lot of hospices are continually battling that and where they stand in terms of supporting veterans, or really any patient on hospice. Yeah,
it's super complex. So yeah, thank you for that. That's a great question. So let's see. So I'll kind of close out with PTSD with some big picture thoughts. One is just to remember that where a veteran served may not necessarily tell you whether or not they were exposed to trauma. Some non-combat veterans may have served on really dangerous assignments, while veterans who were technically in combat may have served in what were actually pretty safe settings. Just back to that notion of battle mind, remember that the stoicism that our veterans are trained to have can interfere with their acknowledging pain, whether that's physical, emotional, spiritual. Sometimes the symptoms are intermittent and it can surprise people. So educating veterans and family members and staff about PTSD and how it can affect care is really helpful. And remember that not all people who have suffered a trauma will experience PTSD, and that sometimes the experience of trauma leads to post-traumatic growth, which is also really useful to know. I'm gonna move on a little bit, turning from PTSD to moral injury. So I think this is something that is not known as well, but it's interesting because the idea is, so moral injury, Brett Litz and colleagues are the ones who described this back in 2009 as perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. So this is a violation of your moral code that you either witness or participate in or don't stop. And that experience shatters people's moral and ethical expectations. And those can be rooted in their religious or spiritual beliefs. They can be culture-based, and it can really affect people's beliefs, kind of fundamental beliefs about the fairness of life, the value of life. And when those things happen, then moral injury describes that psycho-spiritual aftermath. When I was a practicum student here, I worked in our nursing home and took care of a veteran who was a Marine in the Pacific Theater in World War II. And I just remember his saying to me, like, your whole life, they teach you that it's not okay to kill. And then you go to war and they teach you you need to kill. And then you come home from war and they tell you that it's not okay to kill. And really, I think on some level, he spent all of his 80 odd years trying to make sense of that. So it's not the same thing as PTSD. There are some areas of overlap. So moral injury is less likely to be related to actual life-threatening events. It has more of a spiritual focus. It affects people's identity. And it really can, when you see avoidance with moral injury, it's about wanting to protect people from yourself. Whereas PTSD is more likely to be related to a life-threatening trauma. You see those typical symptoms of re-experiencing kind of hyper arousal, hypervigilance, and the avoidance there is around not getting hurt again. There are some areas of overlap. So there you do see avoidance, you see intrusive thoughts, you see sleep issues, substance issues, thoughts about guilt and shame and negative view of self. So there's some overlap, but they are distinct. And I think the thing that's most helpful to talk about is the veteran experiences that could lead to moral injury. So fundamentally, it can be a perceived betrayal by peers, by your leadership, by civilians. Again, think of the Vietnam veterans coming home to this, people yelling at them, throwing things at them, spitting on them, not hiring them, right? This betrayal, or sometimes a betrayal by yourself. So it can come from things like being ordered to break rules of engagement. I think the worst for some of our veterans is this like feeling a rush of enjoyment, maybe during war or killing, but then you afterwards think, oh my God, who am I? What kind of person am I that has that experience? Sometimes there's within ranks violence. I mean, you probably heard of the notion of fragging, where like leaders are killed by their own troops. Acts of disproportionate violence inflicted on others, like one of my veterans said, this is what we do in the military. We hurt people and we break things. Like everyone understands that being in the military may involve violence, but disproportionate violence, such as mistreating civilians or captured enemy combatants, that can be deeply morally injurious. Or just wishing you had done something that you didn't do, right? Think of the quote we saw earlier. If I had just done X, he would still be here. Like my deepest moral value is to protect my buddy or to keep my troops alive, and I couldn't do it. So those experiences, they transgress your very notion of who you are. I've always said with our veterans, the things that they see can be very hard, but it's the things they do that mark them forever. And that's where we are in the territory of moral injury. So how does that show up at end of life? So life review, which can be very healing in some settings, in this case really can open unresolved emotional and spiritual wounds. people with moral injury feel like they are unable to forgive themselves. They may not be forgiven. They fear they're not worthy of redemption. Just a couple of weeks ago, we had a female veteran who had a new cancer diagnosis. She was actually kind of embracing, because she said, now I know I have an out in this life. But her biggest terror was that she couldn't be forgiven for what she'd done in her life. And when you feel yourself so damaged and so damaging, it's very difficult to trust anyone or be open about your experiences. And it's really a loss of like meaning and purpose. And so how do we show up for people who have this? Formal therapies, including meaning-centered therapy or other therapies focused on identifying meaning, can be really effective treatments. I think outside of formal treatments, sometimes just sitting with people, if they're willing to share with you their experiences, like just tolerating that can be profoundly healing. And often people find that there are important spiritual dimensions. So referring to chaplain or a trusted spiritual advisor can be very helpful. Any questions about moral injury before I shift once more?
Elizabeth, I'm sorry, I'm such a question asker.
It's good.
I'm thinking of this from the perspective of a volunteer who may be showing up to companion one of our veterans on service. And the veteran starts to share things where they've had that moral conflict within themselves. What would be the best way to hold space or respond when that kind of thing occurs?
It's a great question. I mean, I think not pressing people to talk if they don't want to, because again, like for all our value of like life review, for some people, like I had one veteran say, like, my brain is like a series of boxes, and there's a few boxes that are tied with a red ribbon, and we are never going to untie that ribbon. Like, okay. Like respecting their need to keep things unopened if they need to. But if they're willing to open and want to open, I think just sitting and tolerating, like kind of part of the fundamental damage is this sense of I'm so damaged that I am like toxic. And so just being present with that and tolerating that can be really healing. I think avoiding like, oh, it's not your fault, it's okay, you're still a nice person, like kind of not minimizing their pain, but just acknowledging their pain, but maybe also helping them talk about, none of us is just the worst thing we've ever done, right? So like, what have you done? What's meaningful to you now? What have you done in your life that's meaningful? What are the things that that you're proud of in your life? Helping them see that their life has meaning outside of that moral injury can be helpful. Is that helpful?
Thank you. Yes. Yeah. Not
Sure.
saying it's okay and allowing them to be able to say the hard things, kind of with what I'm hearing is almost without reaction, but just holding
Yeah.
that with them.
And I will put in a word for self-care too, right? Because when people do share these things, that impacts us as listeners. And so kind of knowing your limitations and sometimes knowing like, I don't know if I can hear this, or if I do hear this, I need to make sure I'm caring for myself, because some of these things can be profoundly difficult to hear. And so recognizing it's okay to be terribly affected by what you hear. And so the importance of caring for yourself as well, I would really emphasize. I know we're almost at time, so let me just gallop through. I always sort of reach this point in this talk and think, oh my gosh, this is like, thank you for hanging in with me, because I'm not the most cheerful person to spend an hour with. But we're going to talk a little bit about military sexual trauma. I just think this is some important basic information, because I think it's something we don't talk about as much. But military sexual trauma can include sexual harassment, assault, rape, requests for sexual acts to achieve rank. I take care of a woman Marine who was, she had supervisors tell her, sure, I can get you promoted if you'll sleep with me. I mean, like, it just really open, right? Sometimes like it's around preventing knowledge of homosexuality, real or perceived. Think about the whole period of don't ask, don't tell. Sometimes like, if you don't sleep with me, I'll hurt the person you care about. So there's a whole range of things that can cause military sexual trauma. Military sexual trauma is most commonly experienced by women, but more than half of the survivors are men due to the male to female ratio within the system. So I think that's really important to remember, that any male veteran you're dealing with may have experienced sexual trauma. And quite honestly, any female veteran you're dealing with may likely have experienced military sexual trauma. According to a DoD report, 20%, 7% of men and 60% of women have experienced some form of military sexual trauma. And individuals are up to 6 times more likely to develop PTSD from military sexual trauma than from combat trauma, particularly men. I took care of a guy for several years who survived a bad lymphoma and had terrible PTSD from his ICU experience. And we had been working together for a couple of years before he disclosed to me that he was raped by a fellow soldier during Vietnam when they were both on watch. And like, oh, right. That explained a lot of things about his subsequent experience in life, but it can take a very long time for people to share that, especially men. People don't always tell you, right? That whole thing about you don't talk outside your unit. The perpetrator may have been the victim's supervisor. And the reality is sometimes when these get reported in the military, the only action that's taken is against the victim. So you may well have somebody who didn't report. So mental health things that can follow on from MST include panic, PTSD, depression, anxiety. In view of time, I'm just going to skip quickly to physical symptoms, because these are things we might see in a healthcare setting: chronic pain, GI problems, obviously gynecologic issues. And medical procedures can pose a problem in patients with a history of sexual trauma, right? There's this power differential between the provider and the patient. It can be painful. People feel like they lack control. And so as we are caring for people, we can respond with empathy if they share this with us. We can ensure their privacy. Again, this whole voices and choices, making sure people know their voice can be heard and they have some control over their care. And also just knowing, like, even saying to people like, I don't always deal with this. Help me take care of you. Like, knowing your limitations can be really helpful. So that is a gallop, but I wanted to thank all of you. And I wanted to leave you with something more positive. I guess, first of all, I want to say thank you again for all of the work that you do, caring for veterans and other folks who are in need of kind, gentle, dignified care when they are most vulnerable. So thank you for being there for them. And I share these words from Carl Sitter. He was a Marine captain who received the Medal of Honor in 1951. And I loved what he said: go out into the world in peace, have courage, hold on to what's good, strengthen the faint-hearted, support the weak, help the suffering, and honor all people. I feel like that is about as good a description of people who work in hospice as I can possibly think. So thanks so much to all of you. I know we're at the end of time. If there are any lingering questions, Becky, you could message me afterwards, or I can respond by email.
Thank you so much, Elizabeth. Your wealth of information, the stories, we do have a lot to process, but this is important information that will help us, I think, just be more present in a way with our veteran patients. So we really appreciate your time. I'm going to stop the recording.